Hello, I'm Mr. Vikram Dar. I am an ENT and head and neck surgeon in Kent, and I want to tell you a little bit about parotid surgery. So the parotid glands are the salivary glands on either side of your face, and the difficulty surgically with the parotid gland is that within the parotid gland lies the facial nerve. The relationship of the facial nerve, you imagine the facial nerve has 5 branches supplying the movement of your face, and the parotid gland is very similar to that of, say, dough and dough whisk. So they're intimately related on either side. It's not as if it's like a tangerine where it can easily be separated. So in parotid surgery, it's very important to look after this nerve. Your physician will speak to you about why you might need a parotid lump removing. The majority of parotid lumps do need removing. The majority of parotid lumps are benign, but they do, some of them, pleomorphic adenomas, have a small cancerous potential, about 10% per decade. There are some parotid lumps which don't always need removing, such as Warthin's tumours, but we have to be very sure on radiology, clinical examination and biopsy that that is the case. There are broadly 2 types of parotid surgery. One group where you find the facial nerve, and that is a superficial or total parotidectomy, and the other group, which is a smaller operation called extracapsular dissection. You'll be coming into surgery under general anaesthetic, and in my care you'll always stay at least 1 night, and if the drain's producing a little bit too much blood after 1 night, possibly 2. Now I want to talk to you about the risks of these surgeries. We usually use what's called a modified Blair incision, so it's an incision which just comes in front of your ear and then goes around the back and then follows a skin crease down here. It's quite a long scar, but it actually heals up beautifully. I lift up the skin and fascia coming down to the parotid gland in all cases, and then in the extracapsular, smaller operation, we come down onto the capsule of the gland and remove it. These can only be done when the lump tends to be 2 centimetres or smaller, is fairly low in the parotid, away from the nerve, and we're sure it's benign. The more complicated operation is the superficial or total parotidectomy, and in those operations we need to find the facial nerve. There's also a nerve, the greater auricular nerve, which supplies the ear sensory function of the ear, so that when you touch it, if this nerve is damaged or has to be cut to get access, you'll have a numb ear. I tend to find that initially quite a large area is numb, and after a year that reduces to about a 50p coin size on your ear lobe. In the sort of more major parotid surgery, we find the facial nerve. We use a facial nerve monitor throughout to make sure we're following these hair-like branches of the nerve, and we dissect everything above it, and a total parotidectomy would have to also dissect what's below it. Occasionally in some cancer surgeries we have to sacrifice the nerve, but your surgeon will talk you through that beforehand. There's some other very specific risks with this surgery. Because we're taking quite a large portion of the salivary gland away, you can have a little bit of a dent in the side of the face, which is not ideal cosmetically. And of course, because we're taking some of that salivary gland away, the nerves that were supplying that gland to make saliva can supply the skin overlying that area, causing something called Fraze syndrome or post-gustatory sweating, which means that when you eat something, you can sweat on the skin. Most of the time it can be managed, if at all a problem, with antiperspirants, occasionally Botox and more. Some patients, particularly for deep lobe parotids, that's deeper than the nerve itself, can get something called first bite syndrome, which is an acute pain when you bite into something that causes salivation. Another possibility with this sort of surgery is what's called a salivary fistula. As we cut through the parotid, the saliva can sometimes leak out for a few weeks through the wound, but they all settle. And sometimes it can get a seroma, which is fluid collecting on the skin, which for a few weeks needs a needle and aspiration, which means removing it. Of course, with every surgery there's a chance of bleeding and infection, and of course you'll have a bit of a scar, but it heals very well. So we do leave a drain in overnight. We don't routinely use antibiotics, and most patients make a very good recovery. I hope you found that useful.